Good morning, I'm Dr. Jade, and I'll be talking about the module on patient evaluation with chronic hepatitis B infection. The assessment of patients with chronic hepatitis B should include the evaluation of hepatitis B virus risk factors and related co-infections, alcohol intake, any family history of hepatitis B infection or hepatocellular carcinoma, and a complete physical examination. Serological markers for hepatitis B virus, particularly HBe antigen, antibody to the HBe antigen, and HBV DNA in combination with biochemical parameters, which should include serum ALT and tests for liver function, namely serum albumin, bilirubin, and prothrombin time should likewise be done. Other clinical evidence of liver disease by liver ultrasound are necessary for identifying the status of hepatitis B infection and assessing the need for and response to treatment. Screening for hepatitis C virus or HIV co-infection in at-risk patients should also be performed. Furthermore, hepatocellular cancer screening and surveillance through serum alpha-fetoprotein and liver ultrasound every 6 months is indicated for hepatitis B virus subgroups considered at higher risk for hepatocellular carcinoma. The assessment of liver fibrosis is important in managing patients with chronic hepatitis B. It serves to determine the extent of liver damage, rule out other causes of liver disease, help recognize patients who may benefit from antiviral therapy, evaluate response to treatment, establish the best time to start surveillance, and stratify the risk of hepatocellular carcinoma and hepatic decompensation. Liver biopsy is the gold standard in evaluating liver fibrosis. It is recommended in patients not considered for treatment with high normal or slightly elevated ALT levels in patients more than 40 years of age and in those with strong family history for hepatocellular carcinoma. It is of paramount importance to recognize cirrhosis among patients with chronic hepatitis B. Recognition of cirrhosis can be made by physical examination by looking for stigmata of chronic liver disease, signs of portal hypertension and liver failure, low albumin, prolonged prothrombin time, elevated bilirubin, and low platelets are some of the laboratory findings consistent with cirrhosis. Imaging, particularly ultrasound, will show small and nodular liver with coarsened echo pattern. Hepatocellular screening and surveillance using alpha-fetoprotein and liver ultrasound every 6 months is indicated for hepatitis B virus subgroups considered at higher risk for hepatocellular carcinoma as enumerated in this slide, and they're as follows. Asian male hepatitis B carriers over age of 40, Asian female hepatitis B carriers over the age of 50, hepatitis B carriers with family history of hepatocellular carcinoma, hepatitis B patients with cirrhosis, those with co-infection with hepatitis C, persistently elevated HBV DNA defined as an HBV DNA level of more than 2,000 IU per ml, and those with genotype C. How do we follow up patients with chronic hepatitis B who are not candidates for antiviral therapy? In general, patients with viral replication but persistently normal or minimally elevated ALT levels should not be treated except for those with advanced fibrosis or cirrhosis. They need adequate follow-up and hepatocellular carcinoma surveillance every 3 to 6 months. Specifically for e-antigen positive disease with a baseline viral load level of less than 20,000 IU per ml, and normal ALT, viral load, HBe antigen, and ALT level should be monitored every 3 to 6 months. On the other hand, if the baseline viral load level is more than or equal to 20,000 IU per ml with either normal ALT or ALT levels more than 1 to 2 times the upper limit of normal, the viral load, HBe antigen, and ALT should be monitored every 1 to 3 months or every 3 months, whichever is appropriate. Moreover, liver biopsy or any non-invasive measure of fibrosis should be done for patients more than 40 years of age. How about for e-antigen negative disease? The recommended follow-up for patients with e-antigen negative disease who are not treatment eligible is similar to those with e-antigen positive disease as seen in this slide. Specifically, for patients with e-antigen negative disease with HBV DNA level of less than 2,000 IU per ml and normal ALT, viral load, and HBV DNA should be monitored every 6 to 12 months. On the other hand, if the baseline viral load is greater than or equal to 2,000 IU per ml with either normal ALT or ALT levels between 1 to 2 times the upper limit of normal, the HBV DNA and ALT should be monitored every 3 or 1 to 3 months respectively. Similarly, as in e-antigen positive disease, liver biopsy or non-invasive assessment of liver fibrosis should be done in patients who are greater than 40 years of age. Thank you.